Hypertension. In this section, we shall be looking into hypertension, which is a common non-communicable disease in our country, Nigeria. I'm Ezara Ronyeka. I'm a registered community health practitioner. Before we look into this disease condition, we shall briefly look at the pathophysiology and also look at the anatomical component, which organ is affected and which organ is involved. We shall look at that before we proceed with this section. At first, this is the heart. The organs that are mostly affected is the heart. The heart pumping rate is increased, and the blood vessels are also affected, which could either lead to the smaller vessels bursting, leading to bleeding, or picking up an emboli or an atheroma and lodging it due to that high pressure within the circulatory system that is caused by increase in blood pressure. So the heart is the principal organ involved in this type of condition. So we shall look at this in this section. Blood circulation through the heart is a vital process that ensures oxygenated blood reaches the body's tissue while facilitating the removal of carbon dioxide and other metabolic products. The heart functions as a pump and consists of 4 chambers, 2 atria. Through atria, look at the artery here, through atria, the one here and the one here. These are atria. Antrum, the 2 makes an atria. And also 2 ventricles. Look at the ventricles here. So these make up the 4 chambers of the heart. The atria is of upper, while the ventricles is of the lower. Now, we shall look at how the blood moves through the heart. At first, the deoxygenated blood, that is blood that do not contain any oxygen, flows through the superior vena cava. This is the superior vena cava here, the superior vena cava. This deoxygenated blood carries blood that is lacking oxygen from the head, neck, and arm to the right antrum. Look at the right antrum here, and this is the right antrum. Then, from the lower part of the body, the inferior vena cava carries deoxygenated blood from the lower part of the body, such as the abdomen, the leg, and every other organ down here, also to this antrum, right antrum. Then when blood has entered this deoxygenated blood has entered this right antrum, it fills the right antrum up, which triggers the opening of the tricuspid valve, also known as right atrioventricular valve. That is a valve between this antrum and this ventricle. When the filling of this antrum triggers this valve opens up here, which allows blood to flow into the right ventricle. And this is the right ventricle. The blood will now fill this right ventricle. When the blood have filled the right ventricle contracts, also known as systole. It forces the blood through the pulmonary valve. Now, look at the pulmonary trunk here. Between this right ventricle and the pulmonary artery, between this pulmonary trunk or pulmonary artery, there is a valve. And this valve is known as the pulmonary valve. Like this one here. This is how it looks like. But here it's not open, but here it's open. A valve similar to this is found between the pulmonary artery, and this is the only artery in the body that carries deoxygenated blood. Other arteries of the body carries oxygenated blood. So this deoxygenated blood passes through this pulmonary valve into the pulmonary artery. The blood then travels to the lungs. This leads to the lungs. This pulmonary artery leads to the lungs. This is the right lung and this is the left lung. It travels to the lungs through this pulmonary artery or pulmonary trunk for oxygenation. When it gets to the lung, it receives oxygenation, that is, it starts containing oxygen. From there, it now returns to the heart. It returns to the heart, carrying oxygen-rich blood. It returns to the heart through this set of blood vessels known as pulmonary vein. And this is the only vein in the body that carries oxygenated blood. And there are typically 4 pulmonary veins, 2 from each side of the lung. So these two you are seeing here is from the right lungs, and the other from the left lungs, and this other 2 is from the right side of the lungs. Or either ways, this is the right side and this is the left side, either ways. So these 2 pulmonary veins carry oxygenated blood from the lung and empty the blood into the left antrum. This is the left antrum and this is the right antrum. Don't forget that. When it empties into this left antrum, it fills this antrum, and which leads to contraction of this antrum. And this contraction of the antrum causes there's a particular valve that's supposed to be found here. This valve is known as the mitral valve or bicuspid valve. This valve will now open, allowing blood to flow into this left ventricle. When blood fills this left ventricle, the left ventricle contracts, which generates a significant pressure, to pump the oxygenated blood, into the great aorta. This is the great aorta. Through the aortic valve. This valve here is known as the aortic valve. This is where it passes, and from here it moves to the rest of the body. The aorta is the largest artery in the body and serves as the main conduct to distribute oxygenated blood to all parts of the body. When the blood gets here, it branches off to supply the head region and every other organ, while the rest of the blood goes down to the lower part. So this blood flow from the aorta is known as systemic circulation, because from the aorta, blood is distributed through a network of arteries and capillaries, delivering oxygen and nutrients to tissues and organs. After the exchange of oxygen and nutrients for carbon dioxide and waste products, blood returns to the heart via the veins through the superior vena cava and the inferior vena cava. So that is how the blood flows through the heart. However, this particular pressure is regulated by a feedback mechanism, but hypertension results when this pressure is exceeded, and the pressure within these vessels becomes much for a lot of reasons, and which can lead to breakage of these smaller, tiny arteries and veins, which leads to complication, or sometimes may lead to heart failure. The actual cause of hypertension is not known, look at these blood vessels. This is the aorta, and this is the branch of that leads supplies to the heart region. Look at a tiny, tiny one. This might bleed during hypertension. Might bleed when the pressure is too high. See this tiny, tiny one supplying the ear, the eye, the mouth, the tongue. They all branch off from this particular artery. The same way the drainage system drains blood that's deoxygenated from the head region into the superior vena cava and the inferior vena cava. So that's a brief anatomy of lower part of the body. Look at this is the vein that connects. This is the vein that connects to the inferior vena cava that returns the blood to the heart. And this is the superior vena cava that returns the deoxygenated blood to the heart from all parts of the body. Then this is the great aorta, and this is the branch of arteries that supply the heart region. And this is that aorta moving down to the body. At this point, it branches off to supply the kidney. The kidneys got the clean and the adrenal. This is the ureter, that from where the urine is drained to the bladder. And from here, from this abdominal aorta, the blood is sent to the lower part of the body, the legs, and every other lower part gets their own oxygenated blood and all of that. So that is the anatomy of how the blood is circulated in the heart. What is hypertension? Hypertension or high blood pressure can be defined as a condition when the pressure which blood exerts on the walls of these blood vessels, especially the arteries, is above 140 millimeter mercury and 90 millimeter mercury diastole. So remember the force pressure that pumps the blood, and the contraction force is known as a systole or the relaxation, as the pressure within the artery when the heart first contracts is known as systole pressure, and the pressure that remains when it's resting is known as diastole pressure. And this pressure, when it gets to the contraction pressure gets to 40 and above, is hypertension. Then when the pressure that remains after this contraction fades in the blood vessels is up to 90 millimeter mercury, it is known as hypertension. That's the diastolic and the systolic pressure is high. That is why when you tie the cuff of the sphygmomanometer, you are tying it against a particular artery in the arm. So you are trying to estimate the pressure of the blood at systole and the pressure when the heart is relaxing. So that is the mechanism behind that assessment of blood pressure. Normal blood pressure ranges within less than 120 millimeter mercury for systole, and less than 80 millimeter mercury diastole. And this patient should be followed up for 2 years. The normal blood pressure is within 120 to 129 for systole. That's the pressure during the heart contraction. That's the pressure that's found in the blood vessel during heart contraction. Then remember, as the ventricle contracts, it forces a pressure to the vessel. So that force that it forces to the vessel is known as systole pressure. That's the pressure we are trying to measure. If it is too high, it can damage it. Therefore, they can determine the pressure can be in these smaller arteries, which can lead to its bursting or bleeding. So it should be for systole 120 to 129, then for diastole 80 to 84. Then we say that someone is having high normal blood pressure when it is from 130 to 139 systole and 85 to 90 diastole, and such person should be followed up for 1 year. Then we diagnose person to have grade 1 hypertension, that mild form of hypertension, if the blood pressure is within 140 to 150 systole and 90 to 99 diastolic pressure. And that patient should be reviewed and followed every 2 months. Then grade 2 hypertension, also known as moderate hypertension, the patient's blood pressure for systole is within 160 to 179 systolic pressure and 100 to 109 diastolic pressure and should be reviewed or followed up 1 month. Then the grade 3 hypertension, also known as severe hypertension, the patient's blood pressure is higher than 180 millimeter mercury and higher than 110 diastolic blood pressure. The patient should be reviewed every 1 to 7 days. Types of hypertension. We have essential or primary hypertension. This type, the cause is unknown. So that's what's essential hypertension. We don't know the actual cause. Adult essential hypertension is defined as a systolic pressure greater than or equal to 160 millimeter mercury or a diastolic pressure greater than or equal to 90 millimeter mercury. This elevation must be constant and the blood pressure must be measured twice at rest during consecutive consultation over a period of 3 months before you can conclude saying that this person has essential or primary hypertension. Okay. Another type of hypertension is secondary hypertension. This type of hypertension occurs due to existing condition in the patient. And usually you can identify that the actual cause of this high blood pressure is this condition in this. It could be Cushing syndrome, it could be any other condition that led to that increase in blood pressure. Causes of hypertension. Some of the attributable causes include lifestyle, such as increase in salt intake, Cushing syndrome, obesity, pregnancy. Pregnancy leads to hypertension known as pregnancy-induced hypertension, as we all know as eclampsia, preeclampsia and eclampsia. Though after pregnancy, that type of hypertension disappears in the mother. So that's why I say this type of secondary hypertension has a cause, which we attribute as increase in salt intake, Cushing syndrome, obesity, pregnancy, and some drugs. Then sometimes the cause is unknown. What are the risk factors for hypertension? Aging. As somebody starts to get older, the arteries tends to harden for reasons of aging. The tissues are degenerating, and also for reasons of atheroma buildup. Atheroma from fat consumption or lipid consumption, and all of that, they begin to build up on the elastic wall of the arteries. As such, as the heart is trying to pump blood, the heart finds it very difficult to now pump blood. The heart finds it very difficult to pump blood because the arteries are now hardened. So that's how aging comes in. Then also aging comes with other challenges. Then increased salt intake, smoking. Smoking is a risk factor for many non-communicable diseases. Then alcohol intake is also a risk factor for most conditions. High cholesterol intake, which forms the atheroma that builds up in the lining of the vessels, can make the blood vessels inelastic. Family history of hypertension is also a risk factor. Then stress. Stress is a risk factor for many non-communicable diseases. That is why it's always good to encourage your patients and clients to stay off stress. Then obesity. Obesity is also a risk factor, a serious risk factor for diabetes, for hypertension, for cancer. So that is why it's good to encourage maintaining of normal body mass index to avoid obesity. Then diabetes mellitus. Once a patient has diabetes mellitus, the person likely is an underlying condition that can affect the body's system that can lead to hypertension. Signs and symptoms of hypertension: one, increase in blood pressure above 130 to 80, 130 over 80 to 139 to 90 millimeter mercury. The person have insomnia, inability to sleep, because the person's heartbeat will be beating and the person will be hearing it and feeling the palpitation. Persistent headache that temporarily relieved by analgesic but reoccur after a drug effect has disappeared. Drowsiness, you begin to feel dizziness, confusion, vision disorders, your eyes, if it's about to close, you are no longer seeing clearly. Then nausea and vomiting may be present, especially in eclampsia. In eclamptic or preeclampsia, this is the major sign and symptoms in pregnant women. And it's a pointer that this woman might be having preeclampsia or hypertension or existing hypertension. Signs and symptoms of hypertension continued. In an adult, it may present with the following signs, such as encephalopathy. That is, encephalopathy is an inflammation of the brain or disease of the brain. And this presents with persistent headache, vomiting, confusion. The person is confused, as anxiety, there is seizure. That's a pure sign of encephalopathy. Then heart failure might take place, stroke might occur. If any of these tiny blood vessels that I showed you get burst due to increase in pressure, blood will begin to leak. And when blood leak, if it happens in the brain, it can leak in a part of the brain that controls a particular part of the body. That leakage will allow blood to accumulate. And when blood accumulates in that part of the brain, it forms a mass that applies pressure on the brain tissue. And this can lead to stroke. Also, it can also lead to formation of clot. As blood has bursted, it needs to clot. And that clot might be moved from that place to another part of the brain where it may get lodged. And when it gets lodged, that leads to paralysis, because that part of the body will no longer be functioning as the cells controlling it in the brain are no longer receiving oxygen. Then retinopathy, that is blood vision and seeing of phlegm hemorrhage in the person's eye, chest pain, and muscle tremors. These are signs and symptoms that's associated with severe hypertension. Then in pregnancy, like we said, preeclampsia, eclampsia, nausea and vomiting, headache, and vision loss. You should take note of these symptoms: headache, vision loss, nausea, vomiting. They stand orders. If they give you this type of complaint and you don't have idea that this could be hypertension related, that means eclampsia in a woman. You might be looking up the complaint in ordinary headache, you cannot find it. But under maternal health, that's where you're going to find it. So that's one thing. That's how it presents in pregnancy. Then in a newborn, the symptoms might include failure to thrive, seizures, irritability, lack of energy, difficulty in breathing. Then in children, it can present with headache, fatigue, blurred vision, nosebleed, that will bleeding from the child's nose. Facial paralysis might also be noticed. How do we diagnose hypertension? Hypertension is diagnosed through when it is measured in an office or clinic on 2 different days, at least 2 weeks apart. And the systolic blood pressure reading on both days are 140 and above milliliter mercury for systolic blood pressure, and or with a diastolic blood pressure reading above 90 millimeter mercury. The diagnosis might be made also on a single visit if blood pressure reads above 180 over 110 millimeter mercury, or there is evidence of hypertension mediated organ damage. This is more of physicians that will determine hypertension mediated organ damage. How do we measure the blood pressure. This is the standard recommended by the Federal Minister of Health. The patient will have to sit with the back being supported, no talking during and between the measurements. The cuff must fit the arm size, and the arm bare and resting at mid-arm at the heart level. You see? Then the room needs to be quiet, comfortable temperature, no smoking, no coffee, no exercise for 30 minutes before. You have to empty your bladder. The client needs to empty their bladder. Relax for 3 to 5 minutes. You are expected to take 3 measurements at 1 minute interval. Use the average of the last 2 measurements. So you have to take 3 measurements at 1 minute intervals. After a minute, you take another one. After a minute, you take another one. Then you use the average of the last 2 measurements you've taken. Then the feet needs to be flat on the floor. For manual auscultatory, the inflatable bladder of the cuff must cover the arm at least 75 to 100% of the individual arm circumference. So these are the standards for you to actually take blood pressure of a patient within that period of 2 weeks apart before you can conclude that he has hypertension or not. Let's look at the pathogenesis. We've looked at the organ, how the blood flows in the heart. Many factors may contribute to the regulation of the blood pressure and the development of hypertension, including renal dysfunction. Kidney problem can lead to that because the kidney has a particular function in using its renin-angiotensin system to regulate the blood pressure, sodium-salt balance. Peripheral resistance, that is the blood vessel's ability to contract, the vessel tone, the endothelial dysfunction, that is the inner lining of the vessels, the autonomic tone, the insulin resistance, the neurohormonal factors. All these contribute to development of hypertension, how hypertension occurs. In more than 95% of cases, however, no specific underlying cause of hypertension can be found. Such patients are said to have essential hypertension. Hypertension is more common in some ethnic groups, particularly African Americans and Japanese, and approximately 40 to 60% is explained by genetic factor. Remember, age is a strong risk factor in all ethnic groups. Which drugs can induce hypertension? The following drugs can induce hypertension: oral contraceptives, hydrocortisone, MAO inhibitors, and NSAIDs, such as ibuprofen and aspirin. Also note that environmental factors such as high salt intake, heavy consumption of alcohol, obesity, and lack of exercise also contributes. Remember, impaired intrauterine growth and low birth weight are also associated risk that increases the likelihood of a child developing hypertension later in life. Complications of hypertension. One of the complications is ischemic stroke. This is a complication which results when the arterial blood pressure is on the high side. As this happens, the arteries of the smaller size suffer it most. This pressure may cause tearing of these small vessels and subsequent intracerebral bleeding, which could lead to stroke. I've explained this before. It leads to busting of these smaller arteries, and the person might begin to bleed, and which leads to ischemia, lack of blood reaching that part of the brain, and the person might suffer stroke. Another complication is hypertensive encephalopathy. This complication is a severe life-threatening one caused by severe small blood vessels congestion and brain swelling. That's hypertensive encephalopathy as a result of increase in blood pressure on the vessels of the brain. Kidney damage. The pressure that builds up in the small vessels at the nephron. The nephron is the functional unit of the kidney. It is located here. That's what does the work. So the pressure that builds up in the small vessel at the nephron due to increase in pressure, increase may damage and lead to destruction of the nephron. Another complication is cardiac damage. Hypertension causes aortic unfolding, and left ventricular failure due to pressure at the right ventricle, aorta, and myocardium. As the heart is bearing that force of pumping at a higher force, the heart may become dilated and may lose its tone. As such, may lead to cardiac failure. When do you need to refer a hypertensive patient? Refer patients with resistant hypertension. That is, resistant hypertension is failure to reduce the blood pressure to below 140/90 milliliter mercury with 3 or more drugs. Also, refer patients with unknown secondary hypertension. Also, refer patients in a special group, such as pregnant women with resistant hypertension. Prevention and control of hypertension. Avoidance of excessive salt is the key. Secondly, avoidance of smoking and alcohol. Thirdly, avoidance of undue stress. Fourth, prompt treatment of conditions such as malaria and all of that, diabetes. Periodic and regular checking of your blood pressure is key. Then, nutritional modification that avoids excessive salt intake, consumption of fruits and vegetables, consumption of food free from sweeteners, extra cholesterol loads, and all of that. Classes of drugs used for hypertension. 1, diuretics. Diuretics are often the first-line treatment for hypertension. They work by increasing the excretion of sodium and water from the body, reducing the volume of blood and lowering blood pressure. Examples of diuretics include thiazide diuretics and loop diuretics, such as furosemide. Another group of antihypertensives is angiotensin-converting enzyme inhibitors. This group of drugs inhibits or blocks the action of enzyme called the angiotensin-converting enzyme, which is involved in production of hormone called the angiotensin II. Angiotensin II causes blood vessels to constrict, leading to increased blood pressure. By inhibiting this enzyme, the angiotensin-converting enzyme inhibitors help relax the blood vessels and lower blood pressure. Examples of ACE inhibitors include lisinopril, enalapril, and ramipril. So remember when I told you about that the kidney function contributes to the regulation of blood pressure. Angiotensin is a vasoconstrictor. Like this, it causes the vessels to constrict. So if the vessels constrict, that is, it reduces the opening and increases the resistance. So as it increases the resistance, blood finds it difficult to move through this vessel. As such, giving the heart extra work to do. But this group of drugs prevent these vasoconstrictions. Another group of drugs is the angiotensin II receptor blockers, ARBs. The ARBs work by blocking the action of angiotensin II at its receptor sites. This prevents the blood vessels from constricting and helps lower blood pressure. ARBs are alternative for patients who cannot tolerate ACE inhibitors or have certain medical conditions that prevent them from using the ACE drugs. Example of the ARBs is losartan, cadastan, etc. Another group of antihypertensive is the CCBs, or calcium channel blockers. The calcium channel blockers block the entry of calcium into the muscle cells of the heart and blood vessels. By doing so, they relax and widen the blood vessels, reducing blood pressure. There are two main types of CCBs, the dihydropyridine, such as the amlodipine, and the non-dihydropyridine, such as the dilatazan. These CCBs primarily act on blood vessels, while the non-dihydropyridine CCBs have effects only on the heart. So you know that calciums are important for muscle contractions, and the blood vessels are made of some level of muscles, while the heart is made of the myocardium, which is also a muscle. So without calcium, the heart may not find the vitality to pump. So by inhibiting the entry of calcium into the heart and blood vessels, the blood pressure can be reduced. Another group of drugs is the beta blockers. The beta blockers work by blocking the effect of adrenaline, also known as epinephrine, on the heart and blood vessels. They reduce the heart rate and the force of contraction, thereby lowering blood pressure. Beta blockers are often used in combination with other antihypertensive drugs. Example of beta blockers includes propranolol. Another group of drugs is the alpha blockers. The alpha blockers work by blocking the action of certain receptors called alpha adrenergic receptors. This causes the blood vessels to relax and widen, leading to a decrease in blood pressure. Alpha blockers are sometimes used in combination with other antihypertensive medications. Example of alpha blockers is prozancin. Another group of drug is the direct renin inhibitors. Direct renin inhibitors such as alisacrine work by inhibiting the enzyme renin, which is involved in the production of angiotensin II. By blocking the renin, this medication reduces the production of angiotensin II and help lower blood pressure. So these are the groups of drugs that are used in the management of hypertension. However, according to the protocol in Nigeria, there is a standard which is captured in the national guideline. So it's always recommended in Nigeria as healthcare workers, we make use of that protocol that is given by the Federal Minister of Health for management of hypertensive conditions at the primary healthcare level. Thank you.